Hello everyone, you are watching sqadia.com and today our lecture topic is chronic osteomyelitis. In this, we'll be going through the etiology and pathology, clinical features and imaging which is needed in chronic osteomyelitis, investigation and treatment. Now if you see this picture, this is something which every orthopedic surgeon usually dread. Now if you see it over here, this is probably female. It's a long bone and there's a lot of lucency which can be seen in where there's a lot of sclerosis around it, and there is actually the margins probably have they're not accurate, or they're kind of a wavy, and I cannot appreciate. This is probably the IM intramedullary cavity seen, but over here I cannot appreciate any intramedullary cavity. And now they are injecting a dye through the sinus and it's going right over there and eventually spreading into the intramedullary cavity. So it's a kind of a classical picture of osteomyelitis. There is foul smelling everything, and then there is a sinus in which this constant discharge is coming out, and patient is in agony, and his or her bone is not right, his or her skin is not right, and nothing is going right for her or him. And now if it's left untreated, that is the acute haematogenous osteomyelitis. Provided the patient does not succumb to septicemia, it will subside into a chronic bone infection which lingers indefinitely, perhaps with alternating flare-ups and spells of apparent quiescence. Now if usually sometimes what happens is that patient do take some kind of a treatment, although they do not die of septicemia, but actually from acute phase, instead of completely recovering, they enter into a chronic phase, and this is a never-ending kind of a phase. It goes on and on, lingers for years. So what actually happens is there's acute on chronic infections, that there is acute flare-ups over the chronic infections, but there is always a borderline underlying chronic infection is going on. Coming to the etiology, what causes chronic infection or chronic osteomyelitis? The usual organisms are Staph aureus. Now this is important. It's not always the chronic or acute. The most notorious organism is Staph aureus. Then others include E. coli, Streptococcus pyogenes, Proteus mirabilis, Pseudomonas aeruginosa, Staphylococcus epidermidis, if for example the initial infection was through the skin, and their normal flora of the skin, which includes Staphylococcus epidermidis, if they have spread from the skin due to laceration or a break or some kind of a cut in the skin, and they've reached the bone, they may multiply, and eventually, initially they may cause acute infection, eventually which subsides, not completely resolves, and then eventually becomes chronic osteomyelitis. Now this is another dreadful picture, but that's what actually happens. If you see, this is the limb of a person and it's showing actually tibia, and if I can appreciate, most likely this is the medial side and this is the lateral side, and this is this as you can see over here, this is a wound over here, there's a wound over here, there's here. Probably some of them may be sinuses, and they may be communicating to the intramedullary cavity. As you can see, there is a lot of redness and hyperemia of the skin, there's swelling, and definitely the patient skin does not look good. And if you see it on this other side, it's bone, that is also not looking good. As you can see, there are lucencies which are going through and through the whole of the diaphysis, and this means almost this whole area is involved, almost all of the diaphysis. And actually there is some degree of chronic osteomyelitis present, which is present in almost whole of the bone over here. So acute symptoms mimic acute haematogenous osteomyelitis, because usually a chronic infection is kind of an underlying infection which is going on at a low level. Then suddenly there is a flare-up which mimics acute symptoms of acute haematogenous osteomyelitis, and then there are chronic symptoms which are like never ending and just going on with things. Acute symptoms include pain. Definitely pain would be there. There may be sudden onset and increase in the pain. There would be pyrexia or a fever. There would be redness, as you can appreciate over here. and there will be tenderness. There may be a tenderness usually when it's recurrence flare. There is usually tenderness if the bone is not united and there is movement of the bone, then there may be tenderness. But usually in acute symptoms, the most common symptoms are pain, pyrexia, and the redness. Coming to the chronic symptoms, as you can appreciate over here, there's a discharging sinuses. The tissues are thickened and often puckered or folded inwards. When a scar or sinus adheres to the underlying bone, these sinuses sometimes actually communicating right into the intermedullary cavity, as we saw it in the first diagram. When they injected the dye through that sinus, it was going all the way into the intermedullary cavity. So if a patient comes to you, for example, there is a 42-year-old smoker who is also alcoholic, and for past 5 to 7 years for rheumatoid, he is also taking steroids. Now, if you see this kind is a classical kind of a person who is taking steroids for his rheumatoid arthritis. He's alcoholic, he's smoker, and he had probably had a fracture for tibia, had got his nail done somewhere, and now he's saying there is a lot of pus coming out from those incisions which were done, and there are sinuses. There's a foul smelling discharge, and when I'm walking, I can feel my bones moving inside. It looks like they're not really united. So if that kind of a person comes to you, what would be your approach to that? That would be, you would like to investigate what could be the other possible causes other than the chronic osteomyelitis. To investigate chronic osteomyelitis, we have to think of first the blood and the radiology. And in radiology, it's when it talks about the labs first, it's always blood complete picture. And what would we see in a blood complete picture? Usually chronic osteomyelitis presents as with anemia of chronic disease. Patient will have anemia. If you see the TLC, if the number of cells may be normal, but if you see in the differential leukocyte count, there will be high amount of lymphocytosis. ESR would be raised. CRP may or may not be raised, because usually CRP gets raised in acute settings, but it may be still above the value of 6. Coming to the radiology, when that guy, just give you a scenario, and for example, he is presented and there was some kind of a nail done to his tibia few months to years back, and then what type of x-rays we have to x-ray tibia, which means x-raying tibia epilateral along with the knee and the ankle, because involving the one joint above and one joint below, so that we can see the extent of the disease, which how much it is actually involving. So x-rays of AP in the lateral view, what type, which bone is wrong. If it's, for example, it's foul smelling discharge and the sinus from back of the thigh, which means most likely it's femur, then we have to get x-ray if AP and lateral view of the femur involving the hip and the knee joint. Then we can get 3D CT scans to see what is the condition of the bone, how much of the bone has necrosed, and is there any new reactive bone formation or not. Then MRI. Why we need to get an MRI? Sometimes MRI is helpful, especially when it's involving the sinuses that involve the soft tissue, because the condition of the soft tissue may not be very much apparent on the X-ray and the CT, but MRI would exactly delineate the anatomy of the soft tissue, the myofascial planes around the bone, which would be more visible and better. We would be able to appreciate what kind of pathology exists in these planes if we are going to get an MRI of the patient. Then bone scan, and most important is always it's indium labeled, or it's called as indium labeled leukocytes bone scan, or radionucleotide scan. Now what happens is the lymphocytes are labeled with indium, and they when the lymphocyte infiltration actually occurs at the chronic osteomyelitis site, they usually are as radioisotopes or radioactive, so they can be seen on the bone scan, and this actually appears as a reddish hot discharge on the bone scan. Now this is another diagram which is showing, actually, if you see over here, this is the proximal femur at the hip joint, this is the ankle joint, and this is also ankle joint over here. Now if you see the staging of the chronic osteomyelitis, and then now this was popularized by Cierny and colleagues in 2003, which was later on, with minor alteration, was adopted as a general classification for chronic osteomyelitis. It is called as Cierny-Mader classification system. Now, if you see it over here, staging for adult chronic osteomyelitis, now they've divided into two categories. One is the lesion type, what kind of lesion is present, and then what type of host is present. If a host is a normal host, that there is no immunodeficiencies and there is no, then it is called as type A. For example, this is a type of host compromised by local or systemic conditions. Local systemic condition, as I just gave you an example or scenario, that there was a 42-year-old male who presented us with a discharge. He's a smoker, he's alcoholic, and there is was a nail being done for his tibia fracture, let's say 1 year ago. Then that is kind of host which gets into a B category. But instead, if severely compromised, for example, there's 85-year-old male who had some kind of a procedure done, let's say 20 years back. Now he's come up with there's an infection, a sinus discharge from his leg. There is some kind of plate or rod in place already, and the problem is that he also has third-degree heart block. There is diabetes, and there are so many other issues as well, with a history of transient ischemic attacks as well. Now this is kind of a host which comes under the category of type C. Then if you divide, lesions could be of 4 types. Stage 1 lesion could be involving the medullary cavity only. It's always intramedullary. If you see it over here, if this infection is only involving the medullary cavity, it's intramedullary. If it is superficial, that is, it's involving the periosteum, something involving not inside the bone but not outside the periosteum, that is, it is contained in the periosteum, that is superficial. Once it's actually crosses the periosteum but only involves either one part, for example metaphysis, diaphysis, or epiphysis, then it is called as localized. But if it is crossed the periosteum and it is actually spread through and through the diaphysis as well as along the metaphysis or epiphysis, then that becomes a diffuse type of a swelling. Coming to the treatment option. As we know, for example, it's a chronic osteomyelitis. It's basically involving microorganisms. Now, the first and foremost, it has to be antimicrobial therapy, antibiotics. That drugs are actually needed to suppress the infection and prevent its spread to the healthy bone to control acute flares. And now the important thing is antibiotics are administered for 4 to 6 weeks, and before considering, then that has to be mostly IV. Now some recommend 2 weeks IV and then you switch to oral. Then there is other say that okay, you start with IV and then you add oral after 2 weeks, but usually IV antibiotics have to be given. Coming to the local treatment, if they should involve that part, for example, it's involving leg or tibia, for example, then what to do with it? In many daily dressing of the wound, sometimes you have to do the dressing in BD, that is in the morning and evening, because it's such a discharge is so massive at times that certain patient clothes get sticky and then they get so he or she has to actually change the dressing twice daily. Then colostomy paste, which actually contains zinc oxide around those to protect the normal skin from that sinus discharges, which actually contain a lot of microorganisms and dead particles and dead part of the bone. To protect a normal skin around the zinc oxide paste or colostomy paste can be used, which is usually actually used in a colostomy because normal skin gets excoriated from the bile, but this is helpful in over here as well. In acute abscesses, if there is an abscess present, that has to be drained. Abscess, if present, has to be drained no matter what. Now, what about if there would be some kind of a metal work which would be present? A plate, it could be intramedullary nail, it could be a something like a prosthesis. Now, that is important that if this patient has a chronic infection, now, unless you do not remove that nail or a plate, that you cannot eradicate infection completely. So this is one thing, this is kind of a rule of the thumb, that you have to take out that metal work which is present inside. Foreign implant may prompt surgical intervention to remove the implant and term of fixation. When undertaking operative treatment, collaborate with the plastic surgeon is strongly recommended. Now, why we say that? At times, there was an open wound initially. A patient got a nail or something like that, a plate, and then later on it got infected. Now, due to that open wound, there was a lot of area which has actually become necrosed. And now, if once you take it out that and debride it thoroughly, we may not be able to close the gap which is present. So for that, some kind of intervention from the plastic surgeon, like muscular flap, a rotating flap has to be done so that we can cover the wound and cover the metal work properly. All the infected tissue, dead and devitalized bone, as well as infected implant must be excised. Now, this is something which is a very straightforward thing. Until unless all the areas of the infection has to be removed, we cannot get rid of chronic osteomyelitis. Apply WAC, re-examine. Now, what happens is, in this condition, we have to actually decide about two things. Whether if we remove the metalwork, will bone be stable? If it would be stable, then we can simply remove the bone work, we can do the thorough debridement, and we can get use VAC to actually help in the healing. But if for any reason bone is unstable, then we have to further consider this as well, that yes, we are removing the metalwork, we're doing the debridement, but we have to think of some other mechanism by which we can make the bone stable as well, so that the patient can have a bearable life. Because you cannot just if there is a non-united tibia, you cannot just leave a non-united tibia as such and after debridement, because the patient will not be able to walk. Coming to the treatment options, these include PMMA beads, polymethyl methacrylate beads, which are actually used, and these are antibiotic coated beads, usually vancomycin, so that antibiotics is actually transferred to the required area, and they can be left there for some time, and later second surgery they can be taken it out. There is a Pepanoid technique or muscle transfer that you can use to decrease the dead space as well. That's a specific technique in which is basically used, and there are multiple other methods as well. There is a rear device as well. There's a reamer inspirator aspirator device in which actually the intermedullary cavity is washed off thoroughly of all the dead tissue, and after debridement and thorough reaming. Then there are other devices. For example, if PMA, instead of making it a PMA beads, we can convert this polymethyl methacrylate cement into a rod, for example, and we can place that antibiotic laden rod for some times instead of the intermediary rod we took out of the patient. And so that once the microorganisms are removed from inside, the soft tissue has healed, then the second procedure to stabilize the bone can be done later on. Thank you very much. Keep watching sqadia.com.